Hi, everybody. Thank you so much for having us. My name is Amanda Duggan, and I am presenting with my colleague, Jonah Netland. We are both fourth-year students from St. George's University. I'd also like to acknowledge our mentor, Dr. Aland Berzault from INB Medical Associates in Miami. So today we are presenting a typical presentation of a rare subtype of chronic inflammatory demyelinating polyneuropathy, or CIDP. Our patient for this study was a 51-year-old African-American woman who suffers from an uncommon subtype of CIDP and possible neurosarcoidosis. Her case is unique because she presented atypically with a cranial nerve palsy. So why is this case important? It's important because almost 70% of patients with CIDP are initially misdiagnosed, leading to a mean diagnostic delay of 21.3 months. And untreated CIDP can lead to multiple relapses and more severe disability. So it is very important that we begin to recognize this more quickly. So what is CIDP? It is an immune-mediated neurological disorder that primarily affects the peripheral nervous system in a chronically progressive or relapsing remitting pattern. So it is often thought of as similar to MS, but of the peripheral nervous system. It's also thought of as being the chronic type of Guillain-Barré syndrome. But it is very important to recognize there are a lot of different subtypes of CIDP, so it is very tricky to diagnose. The most common subtype is the symmetric sensory motor subtype, which presents with predominantly motor symptoms, resulting in both proximal and distal muscle weakness, with a gradual onset over the course of several months. However, again, there are different subtypes, so it can also present asymmetrically or with predominantly sensory symptoms, or even as an acute syndrome. The most common misdiagnosis initially is Guillain-Barré syndrome, but you all know that it is CIDP and not Guillain-Barré if the symptoms persist greater than 8 weeks. Other differentials include multiple sclerosis, neurosarcoidosis, polymyalgia rheumatica, and genetic neuropathy and diabetic neuropathy, among other things. A common question is, how do we diagnose this? It is diagnosed by clinical presentation, as well as evidence of demyelination on either nerve conduction studies or on biopsy, as well as additional studies to rule out some of those common differentials, such as an MRI or a lumbar puncture. You can go ahead, Jonah.
All right, so I'm just going to lead us through the case for today. So our patient, as Amanda noticed, is a 51-year-old African-American female. We followed her over a span of approximately 20 years. Her initial presentation was when she was in her mid-20s, and so a woman in her mid-20s with a neurologic condition, a lot of times, MS jumps to the lead differential for something like this. She initially presented with inability to abduct her eye and with ptosis, so affecting her cranial nerves, cranial nerve 3 specifically. There was MRI imaging, and it was seen that there was just an isolated nerve thickening of cranial nerve 3. And so because of just those symptoms, and with just those isolated findings, it was initially thought of as just an isolated cranial nerve palsy. And so she underwent corrective surgery and went about her day. It wasn't until about 20 years later, actually, when she presented with continuing worsening of asymmetric extremity weakness, she was really concerned, and they did a little more of a comprehensive workup. And so as Amanda noticed in our diagnostic retinue, we did more MRI imaging, which showed multiple nerve root thickenings, both cranial nerves as well as spinal cord hyperintensities. And so there was definitely more going on than just an isolated cranial nerve palsy as they initially suspected. She underwent these imaging modalities and saw that the cranial nerves 2 through 6 were bilaterally thickened. And so there was quite a lot of cranial nerve involvement, which is very rare for CIDP, which is why they didn't initially have this on their list of differentials initially. In her inpatient course, she also had a bunch of lumbar punctures that were done over a 3-year span. During her active exacerbations, And these lumbar punctures showed increase in protein levels, which showed that there was an ongoing inflammatory state present. There were no oligoclonal bands, as is often seen in multiple sclerosis. And so that was lower on the differentials because of that finding. In addition to that, there was also lymphocytic pleocytosis and a high IgG index in her CSF fluid, which indicated that there was an inflammatory state, and also led them to believe that there was some form of autoimmune response that was undergoing in this time. Additionally, there was increased serum ACE levels, which a lot of times we can see that in the sarcoid process. And so neurosarcoid was also high on their list of differentials initially. And so she underwent a peripheral sural nerve biopsy, which did not demonstrate any granulomas. And so when there were no granulomas and there were some demyelinating pattern, led them to believe that there may have been some form of an autoimmune condition here causing this demyelination and this asymmetric presentation of her muscle weakness. And so she underwent EMG and NCV studies, which was also very highly suggestive of a demyelinating state. And because this had been going on for some years, they were led to believe that this may have been a CIDP case. So she did undergo IV immunoglobulin therapy, which a lot of times in these cases is not only therapeutic for patients, but also can be diagnostic because if they are responding to immunoglobulins, there's a high level of suspicion that this is some sort of autoimmune response and that this therapy will be beneficial for them. And so she underwent this therapy and she was responsive to therapy initially. So the next question we always have to go to is this an acute inflammatory demyelinating polyneuropathy, so AIDP, which is just a one time, happens only a couple of times over a span of a few weeks, or is this an acute onset of a chronic inflammatory process? And so you can do one of two things. You can look for a proprioceptive presentation. Oftentimes in proprioceptive presentations, this points towards this an acute process, whereas you can also wait for relapse of their symptoms, which is much more of a reliable indicator that this is a acute on chronic condition. And so she did have a return of symptoms after a year or two. And so she was started on regular treatment with IV immunoglobulins a few times a day, a few times a week. And then she also was added on mycophenolate methyltransferase, which is an immunosuppressant to help with this as well. Over the course of a couple more years after we had seen her, she did actually develop a neurogenic bladder as well. And so this is another rare manifestation, doesn't often affect the autonomic nervous system as often as the peripheral symptoms, which we usually see. So just going into a little bit of treatment here. Initial treatment, as we mentioned in our study, is usually immune modulated. So we do intravenous immunoglobulins as well as plasma exchange, glucocorticoids. And if they're not responsive to a single therapy as listed above, then we usually will add additional treatments as well to see if we can combat some of these things. Maintenance therapy is also very important, generally consisting of the IV immunoglobulins, and then just really supportive treatment as well. These patients are going through disabilities, and so they will need things like physical therapy to help rehabilitate them in addition to their medical therapy, and then as well as adjunctive therapy, managing things that come about such as pain, which is very common in a lot of these patients that deal with neurologic pain. And so doing pain management, as well as things such as neurogenic bladder, which our patient did eventually get. And so treating some of those incontinence issues and other things that are affected from the neurologic system is also very important. So just really understanding kind of the diagnostic of a CIDP patient, and then quick treatment can really help prevent long-term disabilities in these patients.
Thank you.